Now we're going to look at stages of healing, what changes and why does it matter within rehabilitation. So we're going to be looking at cellular healing events to practical rehabilitation choices. We're going to be mentioning objective progression criteria and risk management for common MSK tissues. So let's just start by looking at FITT, what it means and how it links to rehabilitation. So FITT stands for frequency, intensity, time, and type. So it's a simple way to prescribe and progress exercise that maps neatly onto tissue healing stages and symptom-led loading. So let's start by looking at frequency. So how often should you be doing these exercises, sessions, exposures to rehabilitation? So for example, isometrics, we do those daily early on in rehabilitation. If we're looking at heavy strength, we might do that 2 to 3 times a week with 48 to 72 hours between heavy tendon sessions. Now, intensity. Now, this looks at how hard the load is. So, for example, RPE, percent of 1 rep max, running speed, plyometric height, or contacts. Now, we increase intensity only when symptoms and objective criteria allows. So T stands for time. So this is the duration of the session or work kind of bout. So for example, for isometric holds, we might only hold for 30 to 45 seconds. Well, we might include a 30-minute continuous run. Now we adjust to respect the 24-hour response. And then you have type. So this is the modality, the exercise category that you're going to use. So normally we would do isometrics, then isotonic, energy storage, plyometric work, sports related movement on change of direction. Now in rehab, we need to match FITT to the healing phase. We need to link it to how objective criteria and how irritable that tissue is. So examples of objective criteria that we may use, so ROM, strength, the hop test, pain measurements, and we normally progress 1 to 2 FITT variables at a time. We also regress it if next day symptoms kind of flare up. So knowing and understanding about the stages of healing within tissue is really important when we start putting together rehabilitation programs. Now, homeostasis and inflammation happens hours after the injury, and sometimes it will go on for about 7 to 10 days. Now, what happens during this stage? We have clot formation, we have neutrophils, macrophage influx, we have cytokine signaling, high tissue irritability, and pain sensitivity. Now, one of the rehab priorities during this stage, now we need to protect tissue, we need to control the swelling and pain, we need to maintain capacity in adjacent regions. Now, we use isometrics for analgesic tolerance. We do gentle ROM with acceptable symptoms. We can look at gait or activities of daily living modifications, and we educate the patient on the 24-hour response rule. When do we progress the patient at this stage? So we look at resting pain, how much swelling is in there. We look at acceptable symptoms and response to light load. And we look at a patient demonstrates the understanding of pacing, so not doing too much too quickly. So the next stage of injury is when we go into proliferation and repair. And this happens between 1 to 6 weeks. Now, what is happening during this stage of healing? We have fibroblast activity. We have type 3 collagen being deposited. We have tissue remaining kind of immature and disorganized. Now, what are the priorities during this stage? So we need to progress to controlled isotonic loading, and this stimulates fiber alignment. So for example, you could go to 3 to 4 times 6 to 12 reps at moderate high effort within 48 to 72 hours between heavy sessions for the same tissue. We try and restore ROM. We begin motor control, proprioception, and we introduce low complex task drills if the symptoms allow us to do that. Now, progression is really important. We use a lot of clinical measures to make sure we're hitting the correct criteria to move the patient on to the next stage of rehabilitation. So when should we progress from the stage of tissue healing? So we look at ROM. So we look at a difference of 5 to 10 from the injured, or percent from the injured to the uninjured side. We look at pain tolerance during activity and how long it takes to return to baseline within 24 hours. We can look at early strength benchmarks as well. It depends on the athlete and it depends on the sport that they're playing. So the next stage is remodeling, and this can take from 6 weeks up to so many months. Now, what is happening at this stage? So we've got collagen that is being realigned, we're increasing the cross-linking, we're improving tensile capacity, and also there are neurofunctional changes that are still continuing with that tissue. Now, rehabilitation priorities, we add energy storage. So we look at plyometric tasks and how can we progress plyometric work so we can look at contacts, height, and complexity. We can do high-speed exposures. We can look at agility. We can look at change of direction. And we can look at sports-related drills. We have, like always through rehabilitation programs, use objective criteria, so clinical measures to look at the progress, especially for return to sport. Now, when should they progress? So when the tissue and the sports specific criteria kind of level up. So they meet with a stable 24-hour response to the stress that we're putting under that tissue. Now, I've mentioned the 24-hour response rule in quite a few of these slides. So if you're unsure about this rule, I'm just going to talk you through it. So if the next day there is pain, stiffness, or swelling, and this increases or the function kind of decreases, we normally regress 1 to 2 steps. So we will reduce volume, intensity, or how complex that movement is. And then we will re-establish tolerance before progressing again. Now, I've talked about the different types of tissue healing, but also we have different types of tissue within the human body. And how does that link into our rehabilitation programs when we're designing them? So we might have muscles. So if we have a muscle strain, we normally avoid early high load lengthening, and we use pain kind of releasing exercises such as isometrics. After isometrics, we might go on to controlled eccentric mid-stage. We then go to high-speed exposure in the late stage. Now, criteria for muscle kind of strains, we look at pain-free sprint drills and functional tests. We look at strength. We use clinical measures. We look at a stable 24-hour response with our patient and with our clients. Now, tendons, so if we're looking or dealing with an Achilles injury or a patella tendon injury, we use symptom-led loading. We do early isometrics for an analgesic effect. We can do high slow resistance mid-stage, and we can add energy storage exercises for late stage. Now, we have a strict 24-hour monitoring kind of guide progression things with tendons. So tendons have a very latent response. So when we put extra load through them. Now, ligaments. So for example, the lateral ankle, the MCL and the knee, we like to restore proprioception, neuromuscular control early, and then we progress to deacceleration and kind of change of direction. We might use a brace, we might use tape with different players. And again, we use the criteria. We look at ROMs, we look at how stable it is that joint. We look at swelling. We might use balance and hop tests. So we all know that hop tests are like a gold standard clinical measure for the lower limb. And we look at symmetrical. So are the right and left ankle or the knee near enough symmetrical before high demand tasks? Now, bone stress injuries. So we have relative rest and graded return to impact. So we need to address the load, nutrition, the sleep risk factors. Again, we only progress running with pain-free walking and pain-free hopping, and we might use imaging or clinical signs. If we're looking at cartilage, we have a gradual exposure to compression or compressive rotational loads. We emphasize lower limb strength and kinetic train control, and we avoid large load spikes as well. So let's look at some practical guardrails. So we've already explained what FITT is. So we only change 1 to 2 variables at a time. So we prefer stepwise progression, so load, volume, speed, complexity, chaos, looking at that. Again, I've mentioned this a lot. We use objective criteria. So we have clinical measures. So we know when to progress that patient, that athlete, to that individual within their rehabilitation program. So at the end of each stage of rehab, linking into tissue healing, what do we need our athlete to achieve to allow them to progress safely and effectively onto the next stage? So we might use ROM. So are you looking at, you want a 5 to 10% difference? We might look at strength. We might look at certain performance, certain tasks. We might measure pain, and we might use that 24-hour rule. Obviously, we work in a multidisciplinary team most of the time, and we need to have that alignment. So we need to have goals, timelines, and messages should be consistent across that team. So talking to the sports therapists, the S&C coaches, and the athletes themselves. These are the references that I used to create this presentation. So if you would like more information, please look directly at these references.